No, Guido. C'est lui. Hello, hello, hello. We have some special announcements. One for the dinner, this evening, the reception here, and we need to advise our spouse, wife. I hesitate, husband or wife, I don't know. And to join us, Say the best way.
No, I have nothing to add, of course. No, I mean, Professor Bismuth, no, he already at least contact all the, yes, and the agreement is that they take the taxi and they get the receipt and they will be refunded here. Huh? The earlier is the better, because you know there is the traffic, so it may take. So. They suggest 5:30. You said 6:30. I suggest 6, which is the mediation.
I have another announcement. We have to think. Okay, today is a beautiful meeting. Thank you, Guido. We will speak about that following days. We have to think next year. Already you think and you discuss between you. We have two options. One is to go to Cape Town, to have, as usually for the IHPBA meeting, only one day, and then to go to the Congress. So it is an option. Second option is to have our own Congress, some part in the world, in Europe or so. But today we have no city, we have no offer. That means we have nothing for next year. So, or you propose attractive solution, or we go to Cape Town. So please discuss between you and decide. René Adam is the president. You are the president of IHPBA.
I will be, if alive.
Okay, in this case, may you invite us to come? Come here, come. Come, René, come. Mr. President, come. Mr. President.
I would be very, very happy to invite all of us and all of you, of course. The only point is what you mean by invited.
I mean what you think about.
Yes, but there is a session of the Compagnons, and I know that Christian Tozo in Austria is responsible of the scientific program of the IHPBA, and the session of the Compagnons is planned in the IHPBA Congress.
Yes.
So
there will be 3 Compagnons invited. 3? Yes. For it is three topics, and 1 Compagnon and 1 non-Compagnon. So there will be 3 Compagnons and 1 chairman. That means 4. Now, I precise. Invitation means no money.
So invitation without money, I agree.
No, but you have to put them in the program.
No, the point is that the program is yet done. It is not my responsibility.
Is yet done?
Yes. The responsibility has been given to Christian Tozo. And all the program is yet finalized by the program committee with Christian Tozo, not only Christian Tozo, but also American, Asia Pacific, and European members and so on. And as a president, I have no clear influence on that.
So you are president for nothing.
Almost.
No money, no program, nothing.
So I propose that when Christian will arrive, that we may have a discussion.
It could be some room free to place one.
Yes. Some safari, for example, or
No. We need a place for speaker. But I think you have 4,000 members of IHPBA. It could be some day before the meeting. Then you have room for Compagnons.
No, but anyway, I think it makes sense that we can organize this as we did in New York and so on. Because in addition, if many of the Compagnons will go to Cape Town, I assume, and so if there is a cost for going anywhere in Europe or in the States or anyway, and they have also to contribute for the HPBA Congress, it will be a double cost. In my view, it could be more simple that one cost, which is the IHPBA Worldwide Congress, much easier, I think.
Okay, I agree with you. It depends the number of Compagnons who want to come to Cape Town. So we will speak about that tomorrow, at the, not after tomorrow at General Assembly, but think about that. And of course, if a majority of the Compagnons want to come to Cape Town, it is solved. Okay, Chairman.
So we open the last session of the day on transplantation, even though I think there will be some presentations which are not transplantation. So we begin with my co-chairman, Lee Gordon. So Lee, the floor is yours.
Working? Okay. Mr. Bismuth, thank you for bringing this group together. And thank you, Guido, for all your hard work. Hugo, no less hard work. Thank you to everyone for being here and the opportunity to talk to the group. One disclosure, this will not be about cystic disease of the liver. As Dimitri pointed out, this is going to be a forum to present challenges, and so I hope that this represents a challenge, and the reason I bring it to this group is to garner advice, suggestions about how we might improve on a little bit of a new program that will be illustrated by this case presentation. So if you'll humor me for that. Hugo thought that was the title from Hollywood, but it's not. So this is the case of a 44-year-old young woman. She has a very, very complex cardiac history that includes being born with a tricuspid valve atresia. She had transposition of the great vessels, ventricular septal defect, all which required very early and emergent cardiac surgery as an infant. The pediatric procedures that she actually underwent, I distilled into something that I thought I almost understood, and that was initially an atriopulmonary connection, what's called the AP Fontan, and I tried to borrow from the internet to demonstrate that here. Let's see how I can do this being the AP Fontan. She had bilateral cryoablation with all sorts of electrical mayhem and an epicardial pacemaker, and finally had an extra cardiac conduit connection, which is demonstrated by this. And the reason that I show it is to actually also make sure I highlight this. So very complex history, yet that she was doing well, and as I mentioned in the prior slide, was 44 years old when we in fact met her. Unfortunately, though, by this time, she's actually suffering considerably with congestive heart failure, an ejection fraction of 20%, very life-limiting for this otherwise young and otherwise very healthy woman. She was having worsening fluid overload that the cardiologists were having more and more difficulty managing, and demonstrated ascites as part of this, had a bit of a hepatology evaluation, and the liver biopsy demonstrated sinusoidal dilatation, and in fact, some amount of cirrhosis, although perhaps not frank cirrhosis like we see so often in other transplant patients. Her CT imaging showed, I suppose you'd say, liver disease, but not the most extreme. And she actually had hepatic venous pressure gradients measured, which you'll agree are fairly unremarkable. So what to do with this otherwise healthy 44-year-old now suffering significantly from heart failure at the age of 44? Now, many of these patients, I mentioned, many of these patients, this was a non-issue some 20 some odd years ago. These patients didn't live really to adulthood in any meaningful way, and so this discussion didn't really come up. So now what to do? continue medical management. She's being diuresed continuously, occasionally a paracentesis, but continue medical management. It's been going okay for 44 years after her major cardiac interventions. Could we evaluate her for a heart transplant? Should we evaluate her for a heart transplant? Sure. Okay. Or should we evaluate her for a combined liver heart transplant? I mean, this is a Compagnons meeting, so I wasn't coming here to talk about how to take care of Fontaine at age 44. So should we consider this patient for heart transplant, but also for... No, her pulmonary pressures are high. Her pulmonary pressures are high. I probably should have mentioned that.
I did not see what her central venous pressure was.
Her central venous pressure is high, but her gradient is low. I didn't show that. But it depends
but that
on, it
would be an
really is a
important point.
fluid-dependent issue. So it depends on how well diuresed she is. If she gets away from her optimal diuresis, her central venous pressures are relatively elevated, causing concern for this congestive hepatopathy, which really is what?
And
Sorry?
but and the pulmonary artery pressure is?
So the pulmonary artery pressure, I don't have that number for you. It's a little bit difficult after the Fontaine.
One of the questions would be whether she has high resistances in her lung vascular bed.
Sure.
And whether that's fixed or not fixed.
So that's a very important question. Without being able to give you the numbers, I apologize. The feeling was that this was not fixed defect, but this was a primary cardiac issue. And this is what we're starting to see in these Fontaine patients. We sort of loosely group them as Fontaine patients who reach this age. So in some ways, the Fontaine gives up. It gives out. It's no longer highly functional. So I apologize, I don't have the numbers, but the pulmonary aspects were not felt to be fixed as a fixed pulmonary hypertension or a primary pulmonary hypertension. That was not felt to be the case. We have seen those patients, however. That's a different animal for which we would probably not.
But that's why probably if you transplant the heart, the liver will recover, would have no problem. She hasn't got a fixed liver from the biopsy.
So how is the liver function currently? So she has ascites and...
She has ascites, yes. She has moderately well-controlled ascites.
So you have evidence that the liver disease is caused by the cardiac insufficiency. So the indication for a heart transplant is not for ours to give,
right.
But for the liver, if you want to propose a liver heart transplant, you have to have some evidence that the liver has a permanent disease. Do you have any biopsy or anything that?
So there's a biopsy that does show cirrhosis, but the question the very difficult question to answer is this a reversible congestive hepatopathy, strictly speaking, or is this irreversible? And the real question is the liver function satisfactory to get the patient through a heart transplant? And that is not readily decided by biopsy because there's no real single system, honestly, to grade the degree of congestive hepatopathy or cirrhosis associated with Fontaine patients. So I would say it's a bit of a gray zone at best. There are patients that we see who have no sequelae of liver disease. I'll touch on a few of these issues later, but have no sequelae of liver disease, but some congestion, and they're managed well with optimizing their fluid management, and they're candidates for heart transplant alone.
Excuse me, Lee.
Yes.
Two questions first.
Sure.
You said you did a biopsy, and what was the result exactly? Did you use the degree of fibrosis with the Banff criteria, and did you try to analyze the elasticity of the liver? So just the reason why I'm asking that depending on the result might tell you if it can be reversible or not. If it's the first of 2 stages.
You're right.
If it's stage 4, you're sure it's not going to...
So this patient had that evaluation, was at least stage 3. This is where, again, it becomes a bit of a gray zone. The other issue I find very difficult in evaluating these patients is the issue of there's in fact no significant gradient here. So we're talking about congestive hepatopathy without significant gradient. But they're also recognized to have major shunts, both intrahepatic and extrahepatic shunts. And actually, that will come up again later. The shunting issue, this long-standing physiology post-Fontan is extremely complicated with shunting. So part of the answer, I suppose that's only part of the answer, but it's the dilemma. This is the dilemma. I mean, is can the patient get through a heart transplant alone? But sometimes the answer is yes, but sometimes the answer is no. So in this case, I suppose if I were to bring all the details of this evaluation to this group, you guys it's already late in the afternoon, this would be too much. So let's say that we worked her up for a combined liver heart transplant. Let's see. Okay. So I guess we should mention a few of the indications. So we already talked about this particular patient, and I want to emphasize that this is a group of patients that we're seeing, the patients with congenital heart disease who've kind of outlived their original Fontan procedures. The patients who seem to have absolute indications are those who have HCC. It makes it a little bit simpler because maybe they fit more the criteria of patients that we would consider for transplant in general. There's also, we've taken care of a couple of patients with familial amyloidosis who we have transplanted both heart and liver. And then I think this bottom category has to be very carefully evaluated because you could open the floodgates for this type of thing if you took on every patient in the United States who has non-alcoholic fatty liver disease and heart failure. So that's not what we're trying to treat. But I would ask you to consider mostly this first group and consider this as something that's not intended to be a tour de force, but it's really intended to answer a very specific problem for a group of patients that probably didn't really exist 20 years ago. So in that context. I showed just a couple of slides. I mentioned understanding that this patient has this Gore-Tex graft here. It's kind of important because the anatomy in these patients is often uncannily crazy. And we've seen patients with prior Fontan, with total situs inversus, with, I mean, it's actually remarkable what these children are born with and what they are able to be treated for at a very early age. But we have had anatomic issues, without getting into details, that we felt were insurmountable. So in this particular case, the patient has this conduit. I just showed a random slice here on the right-hand side to show that, the sort of normal portal venous inflow, nothing particularly special in this particular patient. Sure.
I seem to see varices around the spleen.
Yeah.
Which should not be the case if it were purely a congestive.
So again, we also consider that to be a sign of the underlying liver disease that may not be fully represented. Yes, exactly right.
Yeah.
It may not be fully represented.
It were only a problem of congestive heart failure and liver disease, you should not see varices.
That's correct. Absolutely correct. Yes. So we'll use that as when we sort of weight the scale, we use that importantly to demonstrate the patient has significant underlying liver disease, and this is part of the shunting. But the shunting that we're very used to seeing in sort of liver surgery, liver transplantation, is not the only shunting that goes on. In fact, it's probably the least problematic of the shunting when it comes to discussing sort of the nuts and bolts of the surgery. Maybe I'll touch on that in just a second. But that's a very important adjunct to sort of weighing the need for simultaneous. Yes?
What is that structure that you have, that round one? Is this the IVC with arterial blood? Because I don't understand. In the second image over there, next to the liver, that one, yes.
Yes. That's IVC.
Yeah, with arterial blood.
Well, yes. I mean, there's shunting. Yeah.
Okay.
I think it's just a poorly timed CT more than anything, but that's just IVC. And in fact, I'll just say that in this patient, that's not a barrier, but we have had patients with sort of aberrant IVC, situs inversus, you do have to come up with a way to put them back together. So sometimes that's not possible. In this case, I think that's just IVC. I mean, I know it wasn't her. But
I'm not sure it's the same time of acquisition, and that's another very bad sign of cardiac failure. When you see contrast in the vena cava flowing back from the heart into the vena cava. And you see it's an indirect sign of tricuspid insufficiency, but also of heart failure. And it's bad to operate on livers that have the vena cava opacified at the...
So I'll just mention a little bit about the liver heart operation that we've taken on, because there is published literature on this so-called en bloc procedure. That's not how we've chosen to do it, and I could get into some details of why that's the case. So we do a sequential heart transplant followed by liver transplant, which I think very importantly allows us a period, but a brief period, to observe heart function prior to proceeding with liver transplant. Now, with machine perfusion, we may have more opportunity to observe, but for the time being, we do this sequentially. The heart transplant is done on bypass, which is standard for heart transplant, and we do the liver transplant on VA, vena arterial ECMO, very importantly, and that has to do with the stress of the liver transplant on the new heart, and it's not strictly intraoperative that stress is noted. I can mention a little bit more, and whether we did this piggyback or bicaval is maybe depends on some anatomic details, but is not really the critical issue. I would say more critically, the issue is doing this on VA ECMO, and I'll say that because we have done this without that, and that's why I'm not presenting those cases. Okay, so this is the most challenging part of any presentation, to see if the movie works, but it's very short. This is the most stressful, the movie part. Okay, so I guess the only point of showing this movie is not to show you the whole thing, but to demonstrate that there's a lot of surgery going on. And so we leave the chest open while we're doing the liver transplant, because one of the issues that we encounter is tamponade. And tamponade is the end. Really, one of the biggest issues oops, there we go. So one of the biggest issues in this case actually is not so much the venous collaterals that we're all more familiar with in the abdomen in the setting of transplantation or operating on cirrhotic patients, but are these enormous chest wall venous collaterals post-Fontan. And of course, this post-Fontan is many, many years post-Fontan. They develop these dramatic collaterals, and they're all multiply reoperated chest patients, or we wouldn't be talking about this. It's hard to explain. I would say that it's hard to explain just exactly how much bleeding goes on. So I'd say the number one issue really here is about bleeding. I would say actually number two issue is bleeding. Probably number three actually is bleeding. So the other that comes up, and this is why I emphasize the issue of VA ECMO, is the demands of the cardiac output in a true cirrhotic are more than the newly transplanted heart can handle. So, we're used to cardiac indices, 5, even more. The newly transplanted heart can't handle that. Even the pumps sometimes have trouble overcoming that, which has been part of our debriefings and discussions in some cases that have been very problematic, is how that new heart can handle the underlying liver physiology before that sort of reverts after transplantation. So doing this on ECMO sort of smooths that process out and takes some of the strain and load off of the transplanted heart. To date, we've done 19 of these combined heart-liver transplants. 15 of them have been Fontan patients, and 4 have been non-Fontan. So there were a couple that were familial amyloidosis patients, and 2 that were actually sort of viral cardiomyopathies, just a couple, obviously. Our immunosuppression is not really any different than what the cardiac team in some ways requires. We, on the liver team, follow the cardiac team's immunosuppression. We don't typically induce with thymoglobulin or basiliximab, but we could talk about that at a different time. And just to mention some of our results, and this is very condensed, obviously. Our overall one-year survival is falling into the 75% category. That's far lower than our one-year survival in orthotopic liver transplant in general, far lower. For the Fontan patients, it's obviously lower than that. And I think it speaks to the incredible complexity of those patients and the myriad of details and issues, physiologically speaking, that they have. For our non-Fontan patients, I suppose that's a better number, but it's a smaller number. And I just you know, we talk about transplant as kind of the ultimate team sport. And I think in this case, it's really even more than that. So we obviously, liver transplant team is a part of that, both hepatology and cardiac transplant team. The liver and cardiac anesthesia teams, in honesty, they do sort of an extraordinary job. The OR perfusion teams are part of that intraoperative and postoperative management of the ECMO systems. Our OR nursing is remarkable. I could talk about them all day. The ICU teams that manage these dually complex patients, nursing, pharmacy, social work, and I think I neglected, but not intentionally, to put down the blood bank, because the blood bank is working triple time during these cases. So I present it because it is, I suppose, a novel need to some extent, something that wasn't necessary before. But I present it really for input and help in managing these sort of intraoperative, early postoperative issues and problems that we have, because it has been, if you talk about selection for patients for any procedure, in this case, I would say it's even more. So I'm interested in the input from this group and how we might manage these bleeding issues, these cardiac failure issues, shunting issues, et cetera. So welcome all inputs.
So this is very interesting. One question about your ECMO use.
Yeah.
What access routes do you use, and do you maintain it after the surgery in the ICU or not?
So initially it's aortic root and peripheral. So that gets swapped out for a peripheral via ECMO once the patient goes upstairs, because we almost always try to close the chest and the abdomen by the time we would take the patient to intensive care. So keeping in the aortic root cannula is complicated if you close the chest. So, but that stays in during the liver portion. It allows the heart team to more readily go back on bypass, because that's what they sort of do standard procedure. But eventually we switch to peripheral.
Then you move it to jugular and axillary, and you put them in the ICU.
Yeah.
Okay. One question, Lee. Yeah. I didn't get it. How did you do the transplant? Was it a piggyback or replacement, total replacement on the VIDC?
We've done both. I suppose the terms that would dictate that are more anatomic. So it's kind of the same reasons we might choose bicaval versus piggyback. In our institution, our go-to is piggyback. We do bicaval quite often. I mean, it's that in and of itself is not the real issue. The most important is the outflow and drainage, because often it's quite strange in these patients. I mean, I actually picked a simple one so I could explain it to you, because sometimes understanding the venous drainage is almost impossible to me.
And the last question, if you don't mind, the 63% overall year survival, what was the cause of death, if you can tell us
so
about?
I can try to mention. So one of the issues that we had early on was underestimating this issue of extraordinary cardiac output needs from a newly transplanted heart. And so I think that we made the mistake of taking the patients off of machine support, assuming that in other words, the heart would be transplanted and allegedly by all parameters be functioning well. Okay, so we would just take that at face value and do the liver transplant to find that the demands then were too much. So we had, then what we do is backtrack to go back on ECMO. But unfortunately, we'd end up with an enormous amount of right heart stunning. some of the right heart didn't seem to recover from. So we had a couple of issues that way. Those were, well, we had one death from COVID, okay? So, but the majority of the other Fontan deaths were very early, and they were all kind of essentially related to heart failure, one way or the other, either biventricular or right ventricular.
I think Krzysztof has a question.
I rather commently, congratulations, that's really great achievement. It's, I think, the top of the transplant surgery. We have much smaller experience in Warsaw with the heart and liver combined transplant. We've done altogether 5 cases. Absolutely, I share your opinion that the most demanding are patients after Fontan surgery. Among those 3, we have 2 of them after Fontans. One young guy after about 23 or 24 years old that was transplanted for HCC in the cirrhotic liver.
Yeah.
Unfortunately, he died in the short postoperative period due to probably overcoagulation and diffuse hemorrhage to the 4th chamber of the brain.
Yeah.
But in contrary, the non-Fontan patients are in very good condition right now. They survive since more than 4 years in quite good condition. So I can imagine how great success you have
I would
transplanting more than almost 20 patients. Congratulations.
The impetus for the program really came out of taking care, the impetus came from the cardiologist taking care of these older Fontan patients. There seemed to be a group, so that's where the impetus for this came from. And then there were some patients that we considered as that I mentioned as the non-Fontans, and it's a totally different animal. It's almost straightforward.
Yes, Laurence?
Because I think it's what the best series in the literature, I think, for Fontan. So we had this dilemma. So what I thought that in Fontan, the difference is also that it's extraordinarily bleeding because they has a multiple operation of the thorax.
Yes.
And when we discuss those patients, they are really reluctant to combine because they said it will bleed a lot.
Yes.
And even with the ECMO, it will be, and ECMO is a factor of bleeding also.
It has to be done in
so
coagulation.
my question is, what is the hemorrhage in those patients? How many
You don't
units?
really want me to tell you the number. It's just extraordinary.
It's phenomenal.
So your colleagues are absolutely correct.
You
because
have
these are multiply
extraordinary
reoperated.
results because 63% at 5 years, it's really
Excellent
very
results.
excellent.
Well, we would like it to be better, obviously. I mean, the patients all, made it off the table for what that's worth. I don't know that that's a great benchmark, but we did run into outside of the COVID mortalities, they were all relatively perioperative, and I think that the principal issues were the extraordinary demands and the bleeding can be unbelievable. So even the take-backs and so forth can be unbelievable to the OR. It's the chest wall collaterals. There's no way to get tamponade for the collaterals without getting tamponade of the heart. So it's very difficult for the chest team.
So you let them in the operating room, all open, until the coagulation is okay, right?
Well, we think it's okay.
I saw in your picture that you have a sternotomy, and why don't you do just a single sternal laparotomy?
We could, yeah.
Good.
We could, and maybe with a right side extension. We could.
Last question: what is your contraindication when you have Fontan?
Yeah.
And heart, a liver disease, cirrhotic liver disease.
I think the most difficult discussions are always about whether the patient truly needs the liver transplant or whether this is reversible congestive hepatopathy.
Okay.
And it's hard. The ones with HCC, you mentioned, that makes it almost easy because they have an indication for liver transplant already, and so what are the contraindications that so some of them,
Cirrhosis
yeah.
by Biliary, okay.
Well,
And Fontan, is there any contraindication?
So the patients that we've felt were not suitable have been either because of venous outflow issues, nothing substantive to plug the venous outflow of the liver into, either suprahepatic or even just infrahepatic or side to side, or because of the anatomy. So sometimes we find that the vena cava is on the left and the heart is on the right. So sometimes we can't seem to reconcile. Maybe we're just not clever enough to reconcile the anatomy and how to sort of plug it in, so to speak. The other contraindications, we do try very hard to make sure there are not a lot of other comorbidities. The comorbidities should strictly, or that the morbidities the patient has strictly heart and liver, that they shouldn't be a myriad of other comorbidities because we can barely handle the ones that are strictly liver and heart. Those are probably the two. I would say one other thing. The patient, we've also had trouble with the patients who manifest severe cirrhosis, but I think it goes back to the issue of cardiac output demands. So the more severe the cirrhosis, the higher the cardiac output, a cardiac index requirements, and I think the newly transplanted heart can't handle it. So the ones who are just cirrhotic enough, that's the ones. Not too soon, because that would be terrible. But yes, not too late, I think.
I agree with Laurence. It is extraordinary. It's and the way you show all the collaboration between the team. This is very important. Did you publish this work?
We are publishing it. I bring it to this group for ideas so we can include to the publication so we don't, we can do better.
I'm sure that patients like this are dying without surgery for...
There are other centers. There are other centers, obviously. In Poland, there's centers. In the United States, the two other principal centers that were doing this were at Stanford and at University of Pennsylvania. They've actually kind of backed away from this. The results are improving, but it's very hard to watch it.
This is extraordinary advance. I have a familial record. It was in the 80s. My father-in-law has a cardiac disease and with heart failure. Mm-hmm. It was in August in 80, and the center of the cardiosurgery was closed in France in August. They say no. And then the family decided to transfer in America. And Houston accepts. At that time, there was Debaquet and Cooley.
Yeah.
And Cooley accepted to take him. He arrived there, and for heart transplant, they accept. Mm-hmm. And when he arrived, it was jaundice. Ah. Jean-Pierre Benamou was our hepatologist, and he said, it's normal with heart failure to have jaundice. Mm-hmm. But they say, no, you have a liver disease. It's a contraindication for heart transplant. He died.
Yeah. I mean, I suppose the issue would be to differentiate and distinguish that. Yeah. I'll tell that story if you don't mind.
I think we have to go on.
Yeah.
Thank you very much. Really very... So now, Ugo? Oh, sorry.
Good afternoon. I'm Sylvia from Lisbon Group. First of all, I would like to thank Professor Bismuth and Professor Torzilli for the opportunity of being here today and to present you this 46-year-old male patient diagnosed in January 22 with colorectal cancer with synchronous liver metastasis. And the tumor was RAS and BRAF wild type with microsatellite stability, and the CEA diagnosis was 1.7. This is the CT scan, a diagnose. As you can see here, a lot of liver mets, more than 20, in both lobes. The largest one in the left lobe with 3.7 centimeters. More than 15 lesions on the left lobe. Here the MRI. The MRI confirms the multiple lesions. And in diffusion sequence, you can see a lot of small, deep lesions in parenchyma, in the right and the left lobe. Infracentimetric lesions and deep. So, what would you do?
Well, it's not because we are the last transplantation session that we have to propose transplantation. Right?
Not yet.
Exactly.
Yeah. Complete hepatectomy.
So we start systemic chemotherapy, 10 cycles of FOLFIRI and cetuximab, and this is the reevaluation at July, a significant reduction in liver mets, not the same liver, no new lesions, and partial response in primary tumor.
Primary was sigmoid.
Yes,
Sigmoid.
transition hetosigmoid. Here, the diffusion sequencing. Some lesions disappeared. And now, we discuss again at this point what we propose: continue the chemotherapy, start surgery.
So who would propose surgery? Exactly. Primary, together, rectum first, liver first.
My doubt is regarding the left liver. On the right, I have seen all the lesions, a lot of them, and I think that, of course, we will need to remove the right liver. For the left, you said us that there is 15 lesions.
More than 15 lesions.
More than 15?
Yes.
You have seen with the...
And middle and left hepatic vein invasion. One lesion in the middle in the confluence of the both.
So if we take this into account, even with a good response to chemo, what is mandatory for the indication, in my view, is the initial tumoral status rather than the new tumoral status, because we know that these missed metastases may still contain tumor.
Yes.
So if we want to be curative, clearly, for me, there is an indication of liver transplantation. This is my opinion.
Could you show us the first diffusion MRI at the beginning?
Yes. This one.
So before chemo.
This is before chemo.
We already confirmed this with Primovisc, but we don't have the images here of the Primovisc. But in the diffusion, you can see there are at least 15 very, very small lesions in the left lobe. This is regarding the right that we saw already that needed a right hepatectomy.
Because sometimes we see this kind of patients with a very good response, also with 10 or 15 metastases, with all no tumor when, at the resection, even if you see nodules. So, yes, Eduardo?
I propose in this patient received 10 cycles, you said?
10 cycles.
10 cycles of cetuximab and FOLFIRI. So we have to treat the primary tumor. We have to resect the primary and see what happened. Maybe if you pass near the liver and you see that we are able to clean the left side, maybe you can do that. But I will treat the primary and see near the liver what happened with intraoperative ultrasonography.
Yes, so colon first, other suggestions?
You said the patient was not having any major symptoms from the primary, right? No obstruction, no bleeding, no perforation.
No symptoms, no symptoms.
Well, personally, I can't see a resection solution to this. I don't think we'll be able to achieve that. But, you know, in order to think about a liver transplant, we'd have to demonstrate good biology in this patient. So have you done that? We've seen that the reduction with chemotherapy is your CEA dropping and remaining stable. You're sure there's no extra hepatic disease. All of these have to be satisfied. And I think treating the liver first rather than the primary would be the way to go. So provided you demonstrate good biology, then only then, you know, we think about a liver transplant.
Yes, but the primary is in, sorry. Scusa. Yes, Guido.
Sorry, just because I am the guy of the one stage, I would like to point out one thing, is that if I would have thought about a one-stage hepatitis, I don't know, I should look better, 15 lesion on the left, but if it is true, 15 lesions of the left, it's also not a two-stage hepatectomy. It means it's a transplant. So the reality is, given if there should be room for a one-stage, the problem is 10 cycles with small lesion, because you may disappear the lesion and you make troubling me. The answer I want is the biological response after 4 is enough. And then if I can operate, I operate the liver first now, after 4, not 10. 10 is finished. I have 20 lesions disappeared. It's very difficult to invent something. But possibly the alternative would be potential one stage or liver transplant.
And what do you do with the primary?
If I would proceed with a one stage after 4 and it is resectable, liver, then the primary, because I try not to associate. If I should, because there is a problem with bowel, the risk of bowel obstruction, just remove tumor and deviate. I understand. For the yes, no, he was asking in the event of one stage. According to the transplant, I think but I think that they were thinking about the transplant because 10 cycles. Now they have then they will do the primary, then they will transplant. The story is well known.
We know the story.
Resection. We have a lot of millimetrical lesions, very deep. We will ever be safe that we don't have missing lesions.
Okay, so let's go on with the colectomy.
Let's go on. So in the setting of a multidisciplinary meeting, we proposed primary tumor surgery and resumption of chemotherapy. If exclusively hepatic disease could be a candidate for liver transplant in the future. So a robotic anterior resection was performed August 22, and the pathology confirms adenocarcinoma G2, R0, partial response, partial pathological response, a PT3-PN1. The patient returned to chemotherapy, FOLFIRI and cetuximab, more 10 cycles, more 6 months of chemotherapy, and we will check again at this point. And he proceeds with response, with significant reduction in liver metastasis size and no new liver lesions. The diffusion sequence shows that a lot of lesions disappeared. And we performed a PET-CT that shows no active disease.
That was my point when I tried to make a question. Congratulations. But did the patient got a PET-CT before starting chemo in the first event? Because now you have chemo, and you can rule out the lesions in the liver are no longer there.
Yes, sorry. The patient performs 3 PET-CT scans. The first one, a diagnose that confirms what I show in the CT scan and the MRI, only liver disease, and a CT scan before the primary surgery that confirms only liver disease. And now, because we are 6 months from the primary surgery, and we want to discuss the patient again and make a plan.
But Renee pointed out earlier that these very small lesions, which are myriad through the liver, are too small to be detected with PET. So I don't know how much. It probably is more relevant for extrahepatic staging than for the lesions in the liver.
I will tell you. Now we have 1 year and 3 months since diagnosis, 1 year of chemotherapy, 8 months since primary resection, partial response to chemotherapy, no extrahepatic disease, and a patient with 48 years.
The first PET-CT showed the liver mets was
liver
positive,
mets.
so you have a positive control. So
the first CT scan was the
positive control. So
the
you have
that
liver
disease,
colon cancer, and no other locations.
Yes.
That's a positive control. Okay.
René?
No, I think even with this fantastic response, I would continue to defend liver transplantation in such type of patient, because when we see the evolution of transplant oncology, the paradox is that we cure patients with limited disease. If we take hepatocellular carcinoma, cholangiocarcinoma, and so on, all the transplant oncology is based on the fact that it is with a minimal disease that really we cure the patient. This is the first point. And the second point is the American experience in living-related transplantation has been published recently, showing that at pathology, there is much more disease than on imaging before liver transplantation. So it could be that here, apparently, the radiology is satisfactory, but in fact, I'm sure that we will find, I make the hypothesis that we will find tumor in this liver. It's a young patient, liver only, good response, good biology. I would go to transplant.
Yeah.
Oscar?
Yes, a question for the people who are doing liver transplantation for colorectal liver metastasis. Are you using circulating tumoral DNA for taking decisions in such case? Because here, apparently, there is no activity in the tumor, and perhaps the circulating DNA may be a good tool, but is your advice?
It seems a promising tool, but I don't think that in clinical practice is already running.
Yes, liquid biopsy are a problem.
So I imagine no tumoral circulating cells. What does it mean? It means that you stop transplantation? Possibly. Yes, possibly there is a quiet period for the tumor, but in 6 months it will re-begin. So presently, I'm thinking that there is still no data saying that this could be an argument for doing or not doing any liver transplantation.
René, in Transmet, is there a dosage of circulating DNA?
No.
No. Huh?
No. Okay. Unfortunately, no.
Okay. Go on.
So, at this point in multidisciplinary meeting, we decide to proceed with liver transplant. I would like to show you this. We went, analyzed our series, and this represents patients like this one, patients with more than 20 lesions, a lot of small lesions and deep lesions that respond to chemotherapy. We go there and we resect the microscopic disease. After that, the patient relapses, and we go there again and perform another resection. These patients has a survival, an overall survival of only 11% at 5 years. This, combined with the fact that our patient meets 3 of the Oslo criteria, but actually 4, because the second 2 change the time from diagnosed for 1 year. So he filled all the criteria. We proceed with transplants. Fortunately, patient has a compatible living donor, the sister. Here I can show you the study of the donor, the MRI of the donor. The donor has the right posterior duct drain in the left biliary duct. We planned the surgery using the graft weight, body weight percentage. So the right lobe was the best for the receptor, and as we can see, the left liver was safe for the donor. Some anatomical questions about the donor. We have an V6 and a change in biliary anatomy. This is the cholangiography at this intraoperative cholangiography, the first one and the second one, and here the graft, the reconstruction of the V with the V5 and hepatic vein with a cadaveric graft vein. And here, the final result, the final aspect of the implant. You can see here the reconstruction of the vein and the reconstruction of the bile duct. An eventual post-op with the discharge 10 days after the transplant. This is the cholangiography at day 10 with 2 bile ducts, the anterior and posterior, separately. The donor went well also. And this is the specimen. A lot of retraction areas and multiple lesions, more than 20 infracentimetric lesions with tumor. Active tumor. This is, and here, active tumor. Thank you.
Thank you. I have one technical question. Would you propose a rapid procedure in order to lessen the risk of the donor, because you did a right hepatectomy with 2 biliary ducts, and to do a rapid procedure and take only the left lobe? Would it be an option?
Left lobe
I
wasn't
think the
enough.
experience with rapid procedure, as we all know, is very scarce. I don't know if there is any group with more than 5. Mortality for the recipient is very high still. I think we're not yet at the time of proposing a rapid procedure for these patients, I think this will increase enormously the mortality of the recipients.
Just one question, if you don't mind, Hugo. For this kind of patient where you have so many liver lesions, even very small and active, wouldn't you could consider to do a local chemotherapy inside the liver rather than systemic for that type of patients?
Intraarterial chemotherapy.
Yes, maybe.
Yes, but the problem is injury of the hepatic artery of the graft. If you have an injury of the hepatic artery of the graft, I think it's too dangerous, in my view, to do. It's attractive, but not in a transplant liver, in my view.
And the second,
if you have an opportunity to transplant a right liver, I think that rapid procedure is futile. And the risk of rapid procedure is less than the risk of 2 biliary ducts for biliobiliary anastomosis. So the risk of biliobiliary anastomosis of 2 ducts of the right liver is lesser than the risk of the rapid procedure.
Yes, but I'm talking for the recipient, for the donor.
I preferred me to the right liver to transplant instead of rapid procedure for this case.
Okay. Because roughly the rapid procedure also is that you always have a left lobe. You have rarely problem of finding a donor.
We actually studied the eventuality of having a left hemiliver, but this was the problem was also the graft for the recipients. That was we considered marginal.
I have a question to you. Chemo, adjuvant chemo or not adjuvant chemo?
Difficult. I wouldn't do, I think. This patient had 1.5 years of chemotherapy. I'm not sure if we have any benefits. I think in the Oslo series, no patient has done chemo afterwards.
No. They didn't do systematically, or I would not say dogmatically, but they don't do any chemotherapy post-transplant. In the transplant trial, 68% of the patient has received chemotherapy on an adjuvant setting, knowing that the 32 restant patients had not received because they did post-transplant complication or their status was incompatible for that. We have no data there is no evidence-based data to demonstrate any efficacy of adjuvant, but possibly in this patient it's debatable because she had a good response, but still 20 lesions with active tumor.
Yes.
So this patient is at risk of recurrence, unquestionably.
Hey, thank you very much. I think we have to go on because 2 cases, 1 hour. So very, very nice. Thank you. You introduce Krzysztof?
So our next speaker is Krzysztof, and we've heard a bit about his heart-liver experience. We'll see what he is going to offer us today.
Monsieur Bismuth, chers compagnons, I'm very grateful for having the opportunity to present this case. It deals with the problem already mentioned. I hope that will be a kind of intense discussion. Whatever, sorry. Okay. The hero of our story is a young gentleman at the moment of the beginning of his history of 39-year-old. In February 2014, he was operated on in one of the regional hospitals in Poland for sigmoid tumor. As you see here, resection PT3 and 1A without invasion R0. However, with synchronous liver metastasis, he received the FOLFIRI 6 cycles. And the surgeons at that center, after almost 2 years, decided to operate on him, in the liver. And unfortunately, they have performed non-radical wedge resection, multifocal resection of the liver with RFA of one of the greatest lesions. That was nothing strange that after a couple of months he got the progression. He received the second line of chemotherapy with FOLFOX-F and bevacizumab. Unfortunately, again, after 3 cycles, the oncologists should withdraw the oxaliplatin and bevacizumab for the toxicity, continuing the 5-FU. Then they switched into capecitabine through more than a year. And after the third line of chemotherapy, panitumumab monotherapy, they obtained the regression of the liver metastasis with no extrahepatic metastasis, as you see at this CT scans and MRI scans. And at that moment, he was presented to our department as a possible candidate to extensive surgery. Here you are the CT scans with multiple liver metastasis without lung metastasis. So after the careful assessment with our multidisciplinary team, we tried to assess him to liver transplantation. In the meantime, we found a dominated focal lesion, and according to advice of interventional radiologists, we have we administered the microwave of the largest focal lesion under the CT guidance. That's the standard at our center. The patient was listed. Luckily, he didn't wait too long. At the end of May 2018, he underwent the liver transplantation. The extended criteria donor, the graft from the donor brain death with classical technique and veno-venous bypass. We are a little bit encouraged to perform this first, in fact, liver transplant for this indication at our center, because both the Oslo score and the Fong clinical risk score were favorable in this case. The immunosuppression was quite classical. Shortly after 3 or 4 months, the everolimus was administered to the immunosuppression. Here you are the pictures of the explanted liver with visible very clearly the multiple tumors, also those that were localized close to the inferior vena cava and confluence of the right, middle, and left hepatic veins. This is the CT after transplantation, months after the surgery, showing the good functional liver graft despite the steatosis with the permeability of the all vessels. After almost a year, disease-free survival in this case was 10 months. During the routine follow-up, the small left lung metastasis was found. The radiotherapy was applied. Later on, it was checked that the regression of left lung metastasis. However, a year later, in a PET scan, we found new right, this time, lung metastasis without liver and bone recurrence. We've checked colonoscopy, which was normal, and according to the MDT decisions, the fourth line of chemotherapy was administered, this time with trifluridine and tipiracil. Due to neutropenia and thrombocytopenia, we have to diminish the treatment. But after 4 cycles of this fourth line, we obtained the stabilization of the disease. According to radiological measures, 20% of increase of target lesions. The border is 20%. Next couple of months, the patient got the fourth line of chemotherapy with mitomycin and 5-fluorouracil, unfortunately with the progressive disease, as you see here on these pictures, especially with the focal lesions in the liver hilum, as you see at the second scan. Due to jaundice, we performed ERCP, put the prosthesis to avoid the development of jaundice, and the new line of chemotherapy with irinotecan was introduced. Unfortunately, in September last year, due to multiple metastatic lesions in the liver and very disseminated metastasis to both lungs, the patient died. Here you are the pictures for the last CT scans from the liver and multiple focal lesions in the lungs. That's a question whether this period from February 2014 to October 2022, it's a success or is a failure. Just short comments. Quite recently published review article showed that the idea of liver transplantation is not that much young because the first attempts were performed in 1972, as you see here. The numbers of transplanted patients were not really impressive, not more than 40, 50 patients in the largest series. Contemporary, there are a lot of current studies evaluating liver transplantation for this indication. As you see, the primary endpoint of majority of them is overall survival. The estimated enrollment number of patients also is not too high, about 40 to 90 patients, and we expect the completion of data and some results at least at the end of 2024. Some of those trials will end up a little bit later. So needless to say that to the multidisciplinary team, up to HPB surgeon, colorectal surgeon, and oncologist, that is the place for the transplant surgeon. In summary, of course, we all know what to do with those patients as members of multidisciplinary team. However, I'd like to draw your attention to the correct timing chemotherapy, which is not quite clear right now. And the current evaluation of liver transplantation, where we aim for more accurate patient selection by accumulating the new tools like liquid biopsy, tissue profiling, and nuclear medicine to those factors that are already known, like clinical biomarkers. So it's a kind of a rhetoric question, liver transplantation in metastatic colorectal cancer. Are we ready for it? Thank you.
Thank you, Krzysztof. Very interesting. I think it's really an ethical issue, very important ethical issue in our work, because I think that if we propose this to the hepatologists that follow cirrhotic patients, they don't agree. They really don't agree our current attitude. So, but open for discussion, comments.
Could I ask a question a little bit about the practical aspects of the immunosuppression that you use in this patient, whether you modify that in any way? I noticed that you used significant induction with basiliximab. Then maintenance therapy, was that any different? And do you feel that has an important role for this group of patients, just in your experience and that of others?
Thank you. That's an important question. As I mentioned, that was the first case of our experience in liver transplantation for colorectal liver disease. So at that time, we were really beginners, but we tried to follow the general indication. It means the early taper of tacrolimus and introducing of everolimus, of course, with the taper of steroids. Up to now, we've done at our center altogether with this case 4 liver transplants, but 3 of them were quite recent, within 3 or 4 months ago. So we have no real, based on our experience, answer for your question.
Thanks.
Meet?
I would like, we may answer to the last question in the paper, are we ready for it? But René.
René is ready, but are we all ready for it?
I think of course we are ready. No, the point is what mean ready? It means for what results? And in my view, in front of the organ shortage, when we propose liver transplantation for any indication, and colorectal is one of them, we should try to cure the patient. Because we are in competition, especially not with the pathologists, with the patient defended by the pathologist who said, you are transplant oncologist and you will take all the liver. No. Presently in all the country, including Norway, it's no more than 1.5% of all the liver transplant performed nationally. So it is very, very low. But anyway, we should do our aim to try to cure the patient. And so to the response to, is it a success, is it a failure? Is it a success to have put this patient 8 years alive? It is a failure because we don't cure this patient. So, but I have one question to you, Krzysztof, is that, in fact, when you discover lung metastasis, what is known from the experience of Oslo is that it's an indolent disease. And I didn't see any possibility of local treatment, radiofrequency, resection of lung metastasis. We have now several patients with lung metastasis after liver transplantation who re-become alive disease-free with a good, I would say, local treatment of their lung metastasis. So why you only choose to perform chemotherapy and radiotherapy initially and chemotherapy and not any local treatment, radiofrequency, surgery, removal? Because I suppose that when you discover, it was not multinodular disease in the lung.
Absolutely, you're right. I think we have to think more widely about the possible treatment. However, this early left lung metastasis and initial success with radiotherapy just make us a little bit less enthusiastic to improve very, let's say, surgical treatment to do it. So we gave an initiative more to the oncologists. That was perhaps that's our sin. However, Just to explain, we were...
I challenge you on the multidisciplinarity, because if multidisciplinarity is only the decision of medical oncologists, you know, I challenge you a little bit. No,
thank you, I understand. Thank you for this question.
I come back on my question. René, 1 month ago, present at the ISA meeting in Bordeaux the preliminary results of the Transmet. So the question is, you present, of course, preliminary results, but you said that, you don't say, but you postulate that the result will not change when you finish the study. It almost finished. So the question, adopting your criteria of selection today, may we decide to do liver transplantation to patients according to the criteria of your study?
No, just, Monsieur Bismuth, just a correction about what you are saying. We are not reporting, I would say, the title was not good, and it's my fault. There were not provisional results of the study, because we have not data today to say what is the result of both arms of the randomized study. We have no provisional, definitive, we have no result. What I reported at the ISA meeting was a definitive result of safety and feasibility of liver transplantation. And so, by this way, we cannot conclude that liver transplantation is validated. No, we have no argument for that, but we show that, and I will speak on that tomorrow, in fact, 40% of patients were rejected by an independent committee, and from those patients who were transplanted, 1 out of 5 was not transplanted because of tumor progression while in the waiting list. So these are definitive results, but they are not results of the endpoint of the study. The endpoint of the study is a 5-year survival, and we have not today. So to respond to you very clearly, are we ready? I cannot say. I don't know what may be the result, the definitive result of the Transmet trial. On a, I would say, per protocol, I'm quite convinced that transplantation will do better than chemo. The point is that from 47 randomized patients in the transplant group, only 38 were transplanted. And so, as you know, in a randomized study, the 9 patients who were not transplanted will impact negatively the group of transplanted patients. So it's not so clear.
You compare liver transplant versus chemo in unresectable liver metastasis from colorectal cancer. And there was a huge tendency in the curve in favor to liver transplant. And this was not reported before, and this is our argument with the oncologists to say, okay, before in this resectable, we have only chemo. Now, we have liver transplant, maybe associated with chemo, no, but in this case, the curve with the tendency was, I was impacted with the curve you presented.
Yes, but it's still my fault, but these data should not be, I would say, interpreted in the way you interpret the result. What I showed is the survival of the group of patients who were rejected by the independent committee, and by definition were treated only by chemo, compared to the overall group of randomized patients, meaning those who receive chemotherapy alone and those who receive chemotherapy plus transplantation. I have not reported at all, because I have not the data, the provisional result of the 2 arms. Impossible, I have not the data. But I was able to show what was the survival of patients who were rejected by the independent committee, very low, around 11%, and those of the randomized patient, chemo or chemo plus transplantation, who was around 60%. But it was not the two arm of the study, so this is a small difference.
But I think this is undoubtedly one of the most interesting areas in oncotransplantation, and we'll hear more from René tomorrow about it, and undoubtedly this will come. But just to keep this session moving, perhaps we could introduce Ricardo Martins, who will also speak on the subject of transplantation, perhaps. Similar, but it's an excellent discussion to be continued, no doubt.
Good afternoon. I would like to thank the opportunity to Mr. Bismuth, to Professor Torzilli, and to Hugo. It's always a pleasure to be with all these amazing surgeons. So I bring a case of a 38-year-old woman with no relevant past that was sent to our appointment with a liver nodule that was called by the medical doctor as an adenoma. On the CBC, no alterations. In the chemistry, a slight elevation of alkaline phosphatases and gamma GT. Tumor markers, the CA 90.9 was 3 times normal, and the CT showed this. I have other images with better contrast times. So here we can see this point. No, yes, here. We can see the cava, and we can see the tumor contacting the confluence of the right hepatic vein. In the coronal phase, you can see the tumor surrounding the right hepatic vein, and we could not see the middle or the left hepatic vein. Also, the tumor seems at least to contact the vena cava. So, a lesion, a large lesion in the left lateral segments of the left lobe, caudate lobe, and right lobe, the anterior sector, with 16 centimeters. Intrahepatic bile dilation of the left lobe, invasion of the confluence of the hepatic veins, and no cleavage plane with the vena cava. So she ran an hepatic MRI that showed moreover the same, and the PET-CT, and also a colonoscopy and an upper endoscopy with no alterations. The PET-CT showed a high-grade lesion with a max SUV of 15, no other hypermetabolic lesions, no hypermetabolic lymph nodes, and we proposed the patient a biopsy that revealed intrahepatic cholangiocarcinoma. With that, what to do to this patient, 38-year-old.
Years old, huge cholangiocarcinoma, 16 centimeter, adherent to all hepatic veins.
Yes.
That's it. And,
in the confluence, you could see.
And portal confluence.
You couldn't see even the left and the median hepatic vein. The right, you could see it until 1 centimeter of the confluence with the vena cava.
Okay, let's. Yeah, chemo. Yeah.
Resectable disease, so we probably begin with chemo and durvalumab, and then if there is a response, maybe a radioembolization.
We were in 2016. There was no nivolumab.
On a chemo, and then maybe radioembolization.
Okay.
Okay, let's go on.
So we proposed 3 cycles of chemotherapy, and we re-evaluated the patient. The CT was mostly the same, so I didn't brought the images. There was a slight decrease in CA 19.9, but we proposed the patient a surgical treatment. We began the surgery collecting peritoneal fluid and collecting all lymph nodes from the hepatoduodenal ligament, the common artery, the celiac trunk, and we send them to frozen section. All were negative. And so we proceeded to an ex situ surgery So we are, after the lymphadenectomy, while we were waiting for the results, here on the ultrasound you can see the invasion right in the end of the right hepatic vein. And so we proceeded to the surgery isolating the pedicle elements, artery, bile duct, and portal vein, demarking the lesion guided by the ultrasound. Here we are exposing the inferior vena cava. Upper part now, we are freeing the superior vena cava. Here we are ligating the suprarenal vein. Thank you, I guess.
And how do you film? Is somebody filming?
Yes, someone is filming for us, yeah. These kind of surgeries, we have someone who's good to film. Now we do our modified biiliac aortic prosthesis, and we are building a conduit to substitute the vena cava, and with a prolongation to do a portoprosthetic shunt, if you want to, in order to have the patient in a better condition while we are doing the ex situ resection. So here we are ending the total hepatectomy with cava resection, here the perfusion, and now we are starting to do the upper part of the vena cava anastomosis. Then the lower one. Now we are preparing to declamp, and we are building now the portal prosthetic shunt in order to have the patient in a better condition and no enlargement of the mesenteric territory. In the other room, 2 other surgeons performed a left hepatectomy extended to segments 5 and 8 with reconstruction of the right hepatic vein. The tumor, as you saw in the CT scan, was very close to the right pedicle. And so we left the hilum to the end. We went up until the cava. Here is an aspect of, we are preserving here, yes, an hepatic accessory vein, more than 3 millimeters, we implant the veins in the prosthesis. We are opening the posterior aspect of the cava there. And now we are going to build a single patch for the right hepatic vein. We are cutting the right hepatic vein in the interior part of the liver. Here cutting now we are in the hilum, the portal vein, and then the bile duct with a clot inside. And here we are reconstructing the right hepatic vein in the cutting surface. You use the stent lots of time to perform it and to test it. And then we are finishing to build a single ostium to perform then the anastomosis. So an aspect of the left hepatectomy enlarged to the 5 and 8. All the veins were invaded, the clot, and now we are starting to reimplant the remnant liver. We do a lateral clamping of the prosthesis. We open a larger hole for the right hepatic vein, and here we are opening a smaller one to implant that accessory hepatic vein that you saw us preserving. So first anastomosis of the posterior hepatic vein, it's a V7. And then the anastomosis of the common right hepatic vein that we rebuild. After that, clamping of the portocaval shunt and the portal anastomosis in a way, a normal way for a liver transplant. And then the artery. Here we ligated the gastroduodenal to gain a little bit more of length, to do the arterial anastomosis, and then the bile duct with a T-tube. Patency, vascular patency saw in perioperative ultrasound, and then the bile ducts anastomosis with a T-tube. Final aspect. So, 13 hours, 5 surgeons, no transfusions, a total ischemia time of 4 hours and 20 minutes, and max level of lactates of 6.5. Postoperative period went more or less well. She didn't had liver failure, 18 days in hospital postoperative period, and she went out with anti-aggregation and anticoagulation with a level of anti-10A of 0.5. So pathology revealed the cholangiocarcinoma G1 papillary type with 15 centimeters, with vascular invasion, with vena cava invasion, but without endothelium invasion. 16 lymph nodes, 1 in the final pathology with a micrometastasis of 2 millimeters. All the others negative. Biliary cast and gallbladder without tumor, and it was staged as a T2 and 1 MI. In the follow-up, she did adjuvant chemo, 6 cycles. In July of 2019, she had lung metastasis that was submitted to a lung wedge resection and chemo. 1 year after this relapse, she had another lung resection of 3 lesions. And in November 21, she appears with a mass, a mediasteric mass proximal to the ICV. She starts chemo with GEM-CIS, and 6 months after, the lesion is bigger, and other lesions are bigger too. So here we have a progression under GEM-CIS. And we are 5 years or 4 years after the liver surgery. We had 2 pulmonary relapses. Now we have a relapse that is chemo-resistant. And the oncologist brought the patient to the DT.
Immunotherapy, durvalumab.
We performed the genomic profile, and this patient has the FGFR2 mutation that may benefit with pemigatinib. She started in November 21. Sorry, she started in August 22, and the last CT scan that was performed less than 1 month ago, there is a almost complete response under the immunotherapy. And the other lesions, one disappeared, this one, and this one is much lesser, so she has a stable partial response. We saw a few days ago, she maintains ECOG 0, fully active. She's a teacher. She's alive 6 years and 3 months after liver resection. She has a stable, responsive pulmonary mets with no other locations, including liver. And at the time of diagnostic, I saw this patient with 2 children, one with one year and one other with 3 years old, and they are now 7 and 10 months still here. So, thank you, and we are always we will always welcome the Compagnons in Coimbra also. Thank you.
Well, that was a tremendous presentation, tremendous care of that patient. The multidisciplinary and surgical care is remarkable. We can open for discussion. We'll try to keep in mind a little bit the time. But
I think beautiful video. You should be congratulated for the successful operative procedure and the chance has the patient to respond to this very genetic alteration. But my question to you is regarding the initial treatment. This patient has a huge tumor, totally unresectable, invading all the, I would say, hepatic vein and so on. You did 3 courses of chemotherapy. She responded very well, and you stop. So my question to you, when we are faced with such type of unresectable patient, before envisaging the fantastic operation you have envisaged, why not to have proceed to a more intense chemo, more, I would say, more longer chemotherapy? You were in a dynamic of response to chemo. Don't you think that prolonging the chemo will possibly allow you to do a less extensive operation, more larger margin, and so on? This is I would say, a general principle. So, but probably you have some explanation of that.
The remnant liver of this patient was less than 40%. So when we proposed chemo to the patient, we were trying to figure what to do to this patient. We didn't had this in mind since the beginning, so we were trying to figure a way to resect the tumor. It was the only curative treatment that we could offer her. The more chemo we would do, the more toxicity we will have, and the more the probability of a liver failure after ex-situ we would have. So that's why, in terms of size and vessel contact, it didn't change anything. The only thing that gave us some benefit was the lowering of the CA 19.9. That was the only sign of response we got.
But there are two questions, one from Ugo, one from Pietro.
Yeah, very quickly. First of all, congratulations for the video. Then this is also important to remind us that until now we had GEM-CIS as a first-line response with a very poor response, and we have to remember now that for patients with IDH mutations, for patients, we have immunotherapy for FGFR, for IDH, there are now a lot of subgroups that can benefit immensely from neoadjuvancy. So we have to start using this.
Yes, and this patient was treated before all that.
Right.
She would probably be condemned to die with a pulmonary and mediastinical relapse in 2022. And as medicine goes on, we can offer new treatment to patients we treated 6 years ago and maintaining them alive with fully active life.
Very impressive. Pietro, you had a question?
Again, very much in favor. Congratulations, not just for the video, but also the operation was very good. Then I'm very much in favor of what René says. Chemo, if you have a patient responding to chemo, the idea is that you get sterilized the micrometastasis. And so it's not only a test of time of selecting the right patient, which is what CIRT offers to you, but also testing the right biology also on the microscopic level. And we are pushing the limits for cholangiocarcinomas in our patients exactly with the approach of René. Even if they are plurinodular, even if they respond to chemo, and you test of time it. And in these patients, I would be very interested if you do lymph node sampling or laparoscopy peritoneal carcinomatosis, because one of the most striking successes we had was on a patient who refused that. He said, I want the chemo immediately. And he responded very well. We didn't waste time for laparoscopy for anything. And then he's now 2.5 years with no recurrences in a case which I don't think was quite as bad as yours, but nearly as bad as yours.
Thank you.
Eduardo?
Yes, congratulations for this fantastic surgical demonstration. And I totally agree that if we treat this case, we'll continue. If the case responds, we'll continue with the chemo. More Mars cycles. And I will not think so much in the liver remnants. We have described a similar technique 9 years ago. You must know it. Just with the graft, showing the portal vein with the cava in order to obtain hemodynamic stability in the clamping. You can clamp this patient more than 1.5 hours, and you will have stability. You will not have hemodynamic stability. You will not have a renal failure. Patient. And my question is, if in this case you have not the chance to perform an ante-situ procedure, if you can preserve the part of the ileum, and of course replace the cava, insert the hepatic vein, whatever. What do you think? Did you evaluate that?
Yes. In terms of technique, when we do these procedures, we don't have that much. We have 5 until in the past 5 years. These are patients we normally don't have any confluence of the hepatic vein, so we have to rebuild them. We have to do lots of turning around the liver. Do it in ex situ position is much more easier than in an in situ position. Okay? So for us to rebuild the right hepatic vein in an extension of 4 centimeters is preferable, and we can do it with all time than when we do the in situ perfusion.
Yes, last comment, and then we'll move on.
The problem with the ex situ procedure is that after the liver resection, you have small amount of liver, and you are going to have what we call small foci of an hyperflux from the portal vein. So the artery is going to restrict, you know, because of the compensation. And maybe the arterial thrombosis increase.
Yes, we normally, when we figure that, you see the liver getting bigger and bigger. And we have several works that we can discuss on the other point, mainly in Alps, and that we started in mice, that we modulate the portal venous flow by ligating the splenic artery. But we can talk about that in the other terms, okay? I know. Yes. But we have those works that we started in the mice, and then we went from the bench to the bedside with the patients, mainly in Alps, when we performed more Alps in the past years, and we have some studies about that also. Thank you.
Thank you very much. So, I think, Ibrahim, a fantastic example of cross-fertilization between transplantation and liver surgery. So, Ibrahim, perhaps some living donor from Turkey?
Très heureux de vous revoir après tant d'années, chers maîtres et chers compagnons. So, I will present a case of 2 living donor retransplantation from Memorial Hospital Istanbul Organ Transplantation Center. This relatively new center, but very dynamic, 1,646 liver transplantation in 12 years. Only 6.3% are from DDLT. And the last year we performed 195 liver transplantation, all but 1 LDLT in 2022. It's another world. Pediatric liver program has begun at there's 7 years, and the rate is 20%, almost double of the national ratio. The 43 patients were retransplanted, so the rate is very low, 2.6%, and the 2 patients had underwent 2 LT, yes. The case is a young woman of 30 years old. First LT in other center was performed in 2015 for PSC from DDLT. Second LT, because of chronic rejection, insufficient immunosuppression, she refused to intake the immunosuppressor medicament. And the third LT, hepatic artery thrombose induced multiple cholangitic abscess with iterative biliary sepsis. So, first retransplantation in 2020, the bilirubin was too high and the MELD score is 25, and any salvage treatment like switch to cyclosporine pulse treatment is failed. Graft, the donor is the sister of the recipient, and the graft had 3 biliary ducts adjacent to each other. Biliary anastomosis was performed between recipient, common bile duct, and graft 3 ducts with stent drainage. And after pulse treatment due to acute rejection, the patient is discharged with certicant and cell-saved because of the elevated creatine. You see here the two biliary ducts adjacent, and another 3. The third is not far from the 2 other, and the illustration of the biliary anastomosis. And near 2 years after the first red transplantation, patient is re-hospitalized with laboratory and radiology findings expecting cholangitis and biliary sepsis. You see here MRI, multiple cholangitic abscess, and PTC external drainage performed. And the CT showing the arterial phase is here. And the arterial perfusion is sufficient for the moment. But 4 months after, redrainage of cholangitic abscess due to HAT, biliary sepsis, and admission to ICU. And at this moment, we performed another CT showing that no perfusion, any portal perfusion, and arterial perfusion in the liver. So, multiple PTC drainage were performed due to cholangitic abscess, and you see here in a PTC extern and 10, and the multiple cholangitic abscess here. With improvement, remission of the biliary sepsis, the patient permit us a time interval of without sepsis, and in this clinical status, the patient is transferred to service from ICU. Meanwhile, the second retransplantation was decided. Second living donor, the second sister, is prepared, and the patient underwent to second retransplantation in 22. Portal vein and hepatic artery were isolated. Thrombotic hepatic artery was excised. Normal intima was reached. End-to-end portal anastomosis with cadaveric iliac vein interposition was performed. The IMA was removed 5 centimeter, and the common hepatic artery and graft right hepatic artery were anastomosis with interposed autologous IMA graft. 2 bile ducts were in the shape of glasses, and a single duct anastomosis was made through the biliary tract. Here you see the explant, the third explant, yes, with multiple biliary abscess. And here, the 2 bile duct with anastomosis, and the illustration of the anastomosis. The common bile duct of the patient was utilized 3 times for biliobiliary anastomosis in this case. And here you see the interposition of the iliac vein between the portal vein of the recipient and the right portal vein of the graft. Okay. And autologous IMA graft is prepared from the aorta, abdominal aorta. And this is the recipient hepatic artery. There is a tension between the graft hepatic artery and the recipient hepatic artery. So the IMA is prepared, and between the interposed between the recipient hepatic artery and the right hepatic artery of the graft. Okay.
You do those anastomosis with microscope, or do you use microscope?
Microscope, yes, operator microscope. I want to pass to 2 days after, you see here the arterial anastomosis is open and portal anastomosis also is open. The patient transferred to service at day 8, and at day 12, was discharged with bilirubin 31 and creatine 0.7. Last control at 4 April was really, almost correct. The case, the series is published recently in the transplantation proceedings. There's 2 months, and I will, as conclusion, re-LDLT has shown comparable outcomes to re-DDLT, if not better, even not far from significance, p equal 0.058. These results may encourage performing re-LDLTs in patients with indications for re-LT without worrying about low chance of survival, especially in countries with limited sources of deceased donor. You see the comparison of patient survival between groups DDLT and LDLT. There is a difference near the statistical difference. Okay, it was the same conclusion. Thank you for your patience.
Well, impressive numbers, very impressive numbers. Ibrahim, yes?
Skills. Am I correct in what patient you presented? The first LDLT failed because of non-compliance for
non-compliance of the patient, yes.
So my question to you is, you know, an ethical issue, 30-year-old patient with non-compliance, why are you confident that you can achieve a good success with a second LDLT? You might have the same problem again. And is it ethically okay to put a donor at risk if you don't sort out the problem of non-compliance?
Yes, there's a risk of a second non-compliance after the third transplantation, but psychologically, she is prepared before the third transplantation, because the family insists also. The second sister was very demanding for the donation. So we decided to give him a second chance, a third chance. And our chance was that we found a time interval without sepsis. And in this time, we could prepare the second living donor for the third transplantation. I think that the difference between DDLT and LDLT retransplantation is why it is in favor of LDLT, because we can find the donor, the compatible donor, the ideal donor at the moment, at the critical moment. And the country as Turkey, we cannot find a deceased donor for this.
Thank you for sharing that experience. It's certainly dilemmas that we don't all necessarily face in our countries, the necessity for using living donor. It's fantastic. Thank you very much.
Okay.
Our last speaker in this session is Mark Bemelman, who will be speaking to us about, we're about to find out.
Yeah, we'll find out.
About to find out.
Always an Honored to be here, specifically on 7 o'clock at night. So don't worry, I made it a little bit shorter in the plane. I have two simple questions, actually. First is, indeed, I didn't know before, resect or transplant? And second is a little bit philosophical. The case is relatively simple. 46-year-old female, rectal carcinoma with liver metastasis. In our opinion, not resectable at this moment. So we decided to start the chemotherapy. So I'll show you the reason why. There were some metastases. Let me show, yeah, it's that simple. But this one was the real problem here. So there are some little ones on the left, there one, and there's one here, I think. But the problem was more over here. So all the veins, caval vein, right, left, everything was in it. So we decided this should go for chemotherapy. Let's go. And so indeed, we decided to go for chemotherapy. First radiotherapy on the rectum, and then some Capox-B and some irinotecan 5-FU, panitumumab. Everything was given. The timeline was a little bit that we did the chemotherapy, and after a few months, we did a re-evaluation. There was reduction in dimensions from those liver tumors, but still not resectable. The rectal tumor, however, showed already a complete response. So the MDT, I show you the pictures, decided, well, that means that it's not resectable at this moment. Maybe it's better to go on and go with the chemotherapy and try to get those liver tumors more in reduction. So we went on, and we went on till the beginning of this year. So then almost 11 months of chemotherapy, and then we said we're going to take a definitive decision to resect or to try to enroll in a liver transplant program because of the veins. But in that case, we had the problem of the rectal tumor. If you're doing a transplant, you have to resect the rectal tumor. Complete evaluation done. Endoscopy, nothing to be seen, nothing to be palpable. Biopsies negative. So the rectal tumor had a complete endoscopically, macroscopically, pathologically response. So for that rectum, we said follow-up. We did a CT, I'll show you in a minute. The metastasis still visible, two smaller ones not recognizable anymore. One nodule in the lungs, which was atypical, not suspect, was all the way already there. No new metastasis. MRI doesn't give you extra information, actually. So this was actually the decision now. And now the metastasis is much smaller. The other ones are not a problem, and we were discussing about this one here, where still the middle, the left, and also here the right were included. And that was a little bit the point, what to do then. So this was our decision. What would you do now? So you have the rectal tumor, complete remission, and still tumor quite close here. The other ones are all resectable. That's here one, and there's one. That's not important. It's because of this one here. It's still all well, at least the left and the middle, and the right is very close, or not.
So, question to the floor. What would you do? Hugo?
This is tumor. This is tumor. This is tumor. And the right is still, yeah, here I think it's free. Here it's tumor. It's really close, the right side. Middle, left are in it.
So I suppose you could try to do a left extended with reimplantation of the right.
Yeah.
But it's probably
because of the...
I think it should be sent to Coimbra.
Yeah, could be. That's good. Well, there is another point which...
Portugal in general, because Hugo does that.
No, it's okay.
Yeah, well,
it's fine also.
The problem was a little bit that we were there, transplant versus resection and reimplantation. Well, there was one point, the patient had also an opinion, because she said, if I do a transplant, I have to remove my rectum. My rectum is now good, so Transplant is not so interested for me. So we decided to do an in-end left hepatectomy, clearing of the corner caval vein and right hepatic vein. We discussed there of reimplantation of the vein. We haven't done it. I still don't know. It was last week, so I don't have the definitive pathology. We discussed it. In the end of the operation, we thought we were free, but we were on the edge. We don't know. So that's where we are. So this was a little bit of
vascular R1.
Pardon?
Vascular R1.
Yeah. So we'll see. And the philosophical now, just before the drinks, that's always good. Because this patient was sent from the Netherlands, here, from somewhere else, from St. Elsewhere, I call it. And the Netherlands, you have 17 million people. We have a Dutch hepatobiliary audit and a Dutch pancreatic cancer audit. We have 14 pancreatic centers, 20 liver centers. From those centers, there are HPB centers. So sometimes you have only liver, only pancreas, and some HPBs. And the guidelines in our country already, since several years, you're obliged to do at least 20 pancreases or 20 livers a year. If you don't, you're not allowed to do it. You don't get paid. But now, it's starting now. We have a new Minister of Health. He's coming from a hospital, and he said, you know what? 20 is much too low. I want 50 or 100. So now the Netherlands is completely a mess, because everybody is afraid, because what would that mean? That would mean that centralization, imagine, 50 Whipples a year. But there are a lot of hospitals who perform 30 or 35. They should close down. That's one. But those 35 should be operated in another center. So if you're going to calculate, that would mean, for example, they say, yeah, you know what? You get 120 Whipples extra and 150 livers extra. And that's the problem. We don't have place for that. So we're now a little bit in between. The numbers will be checked, so you cannot not operate or say something else. Those numbers will be in the DHBA. Those audits will be checked and checked. You will not be paid by the government. You will not be paid by the insurance companies. So there's going to be a number. But all those, the relatively smaller pancreas and liver centers probably have to close. But centers doing those 50 livers and 30 pancreases, like in England where they said from one day on, we're going to change it. But that means a tremendous impact on the logistics. And if it's possible, we don't know yet. We are already full. Money, reshuffling, we don't know. So it is an interesting question in the end before the drinks. How is it handled in the rest of the world? What would you think? What would be the number sufficiently for livers and pancreases to perform good liver or HPB surgery? And it should be payable, and it should be also for the hospitals acceptable. So that's where we are now, exactly this day. We don't know what's going to happen, but possibly a lot of centers have to close who perform 35 Whipples. And it's our Whipples, pancreatic resections, not tails, Whipples. Open, closing, no Whipple, just real DPCs, just Whipples. So you have to perform actually 50, 60 pancreatic resections to have 35 Whipples. But they have to close down then. And they have to go to the bigger centers, but those bigger centers get them from 3 or 4 smaller centers, 100 Whipples extra. And they don't have any space. So it's an interesting vision what's going to happen. I don't know.
The question is about centralization of the activity and probably in the hospitals a redistribution of type of surgery, because let's say small surgery will go on the other hospitals. So
yes. You don't think the risk also could be that the small center increase the number of people, for instance, when it is not indicated?
That it's a possibility, but you have the audit. We've seen it in breast surgery. Then the audit comes in, they check the data, and they also check the quality. So the quality will all be checked. If you are outside the funnel plot, they'll knock on your door. They ask, can we see your data? Are your data correct? That's first. Maybe you didn't fill out your forms correctly. And if you're outside that funnel plot, they say you have a problem, and we'll watch you. And if you don't ameliorate your numbers, we'll cut you off.
Now, for this new minister, what is the objective? To do economy?
No, he thinks it's going to be better. He says bigger numbers are better. Well, in the beginning, that was good.
Yes, but for quality or for economy?
Quality.
No, it is interesting to have this type of extreme centralization, and you have given in the past a good example to all the countries about the interest of centralization, especially for pancreatic resection. But I give you the other extreme. We have recently published in my country, in France, the threshold to be, I would say, valorized, to be recognized as a specialized center for liver, pancreas, rectum, and esophageal. And you know what is the number that is considered as for expertise? Is more than 5 a year. Not for a surgeon, for the team. So no comment.
No. But we are already for breast, for esophagus, for stomach, rectum, we're already at 20. So everybody performing less than 20 are not paid. So they close. So nobody in the Netherlands perform less than 20 esophagus, stomach, liver, pancreas, rectums. Everybody performs more. But now they want to go, and this is the beginning with the pancreas and the liver. They want to do it with rectum. They want to do it with breast. It's going to be 250 breasts in one center. Otherwise, close it down.
It has increased to 10. I don't remember. I don't know if Laurence is here, but it's so low. Laurence, Jean-Philippe, it is 5 or 10 in France? 5.
Yeah. Jina. Oh, no.
It's just, and I remember I had a discussion with you because I was impressed how Netherlands was working in terms of centralization and everything. But the problem is, as you said, if they start to doing this, what are you going to do? Because I agree, why not in a small country having big centers where they are absolutely excellent, you know, in matter of their work. But the problem is, as a surgeon, if you start to close, they don't hire you. Where are you going? There's not enough money. Are you going to make a team with 50 surgeons doing this? So that's going to be the maximum of...
England has some experience.
I did that. I agree.
John has a comment, I think.
Yeah, about what it was about 15, 16 years ago, they decided on the centralization. Centers that were doing 4 or 5 Whipple a year were forced to close, but it was more gradual process. I mean, we all know that there's almost no bottom line to reducing mortality in Whipple. The more you do, it keeps dropping, and that's not the surgery, that's your whole setup. It's radiology 24/7, you know, your ability to save, bleeding, etc. So there is, you know, broad agreement that you should centralize, but you need to have support for, you know, surgeons, etc., clinicians who want to engage, and that can be done. You can develop big centers, and centers that have to stop, well, the surgeons can come and do their operating at the biggest center. And I think that works very well. Everyone is pretty happy. They develop clinically, but you do get that huge volume in fewer centers. And just to give you an example, transplant is another thing in the UK. We have the same population as France, and we have 7 centers in the UK. And we have about 28, 29 pancreas centers right now. So we think it is working quite well.
Eduardo.
Yeah, I need to speak with your minister. Because I have been nominated in Portugal a month ago as the president of a commission to audit and to put these reference centers working, you know. And there are a lot of problems, you know, because now in Portugal we have 4 surgeons suspended by the Ordem dos Médicos, the College of Surgeons in Portugal, because they have done operations that are not prepared to do. So, one thing I ask you, have you been informed, the population of the Netherlands have been informed that the best place to be operated perhaps is not nearby his home, but perhaps to go, because in Portugal, if we explain to the patient, you know, okay, if he lives in Algarve, if you have a pancreatic cancer, the nearest center to be operated is in Lisbon. It's not in Algarve because they have only 4 or 5 patients per year. So I think that's very important to do that in all Europe, you know. And I think there are directives from European community to do that. But okay, to finish, I tell you, this is happened in the United States. There is some people from the United States in the last century. Francis Moore said a sentence very important, that every surgeon in the United States was against specialization, except the patients, you know. And we need to explain this is not a problem of money. This is not a problem of to spend less money. It is a problem of to offer to the patients the best possibility to survive and to have long-term survival. And to finish, when I begin with the help of Henri Bismuth, the center in Lisbon, the Hepatobiliopancreatic Center, in 2005, there is no legislation. But in fact, all the hospitals in the south of Portugal, after begin to send the patients to us, you know, and you achieve in the last years more than 500 liver resections per year. And 130. Transplantation is very easy because nobody wants to do transplantation, you know. Only 3 centers in Portugal. But to do pancreatic surgery, liver surgery, everybody thinks they are allowed to do that. But I think that will be a very nice thing for the Compagnons Hepatobiliaires to lead this fight for specialization and to concentrate the Professor Bismuth. I think that would be a nice thing that if the Compagnons outside of the clinical discussions have also this kind of discussions, because you defend specialization for a long time ago. And it's because of the patients, not because of money. It's because of the life of our. I think that I am going to have big problems in Portugal.
Yeah.
I know me very well. I think that it will be very difficult for me because I am going to do that with strong, with my way, in my way. So, but okay, but 5 is ridiculous, you know.
Yeah. I think there is a limit in the number.
Yeah.
I mean, you know, if you do 100, okay, you may go to 200 to 300. I think I have a provision. I may predict something. If it works in Netherlands, it will go to the European community. And they will decide to extend for all Europe, not only by country, but in all Europe. It could be there will be 1 center in Europe for pancreas, 1 center for esophagus.
Who knows?
And then, no, the patient will wait for months and died in the waiting list, which is good for economy.
It's good for economy, yes. But the problem is that the reality is very different in small countries like Holland, Belgium. It's very easy to do centralization because the patient does maximum 200 kilometers, maximum. But in bigger countries, it's much more difficult. So the British example might be interesting to analyze. I don't know how it works, but in... Yes. Like in Belgium.
May I ask a question, Valerio?
Yes.
Mark, which is the position of the Dutch Association of Surgery about this? This is the first question. And I think that it's a very important, the audit of the results, the outcomes, more than the number.
The Dutch Society has started, the discussion about 20 was started also in the country. Everybody was talking, and then the surgeon said, at a certain moment on the board, he said, you know, we have to do something because otherwise somebody else is going to do it for us. And then we made it 20. But I can tell you, going from some people who did 12 to 0 gives a lot of stress. So that was a surgical department who did it. Now it's the minister. This was not by the surgeons This was done by the minister, and he cut, maybe if somebody followed, heart surgery was in 4 centers, and he said at a certain moment, you know what? I want to have 2 centers closed. Finish. And I'll decide in 2 months which 2 is going to be. And he just said, it's going to be Groningen, and it's going to be Rotterdam, and Leiden and Utrecht will be closed. Okay, thank you very much. Next question. So that's how he works. But that are small numbers. Now these numbers are bigger. So now, but there will be changes in the Netherlands, I'm sure. There will be changes. There will be more centralization. There will be coming something. And mostly, the Netherlands is relatively early always. I think, like also in what happened in Britain, it'll come somewhere else also. It's going to be liability about patients who are suing doctors who are performing 10 or 15 or 20 operations. It'll come, I think.
I can give the Belgian example, because in Belgium we had centralization for pancreas surgery and for esophagus surgery 3 years ago. And so it was, the level was set to 20. And as you said, the small centers, which were just on the edge of the, they made some over indications probably, and overall, so after the 3 years analysis, the primary goal, which was a better quality of surgery, so we had more mortality overall, and so it's being discussed, of course. So we see that the big centers really rise their activity. For example, in our center, we went from around 30 whipples a year. We had usually 30 to 40. Now we are 100, 110 whipples a year. So really a big augmentation of activity. René?
I have just a suggestion, seeing the interest of this discussion. Why not to do a companion paper about the discrepancy of the, I would say, the threshold of expertise in the different countries that we represent? I think it would be very, very interesting, because we have almost all the very, very different countries, and such to report what may be the tremendous difference between, for example, Netherlands and France, between I would say, the good attitude apparently with more resources from Britain, the difficulty in, why not? I think it's a possibility. Now, who will be in charge of doing it? Yes, why not? Yes. Yes, yes.
Okay.
So just do it. Nike.
Have this in our representative, and I contact all the companions. Yes, you can. Yes, I can.
Yes, I can. This
yes,
is nice
you can.
end. This is the end. Just.
We close
It's
the
good.
session. Yes.
Just for the drinks, huh?
So with this nice picture, I think we close the session. So that, thank you very much.
Another announcement. Another for tomorrow, that the session will be on YouTube. Thanks to Guido. Guido, come. So tomorrow, the session will be on YouTube. Please ask your team to look at YouTube. We need to have the link.
They will send a link, is a Zoom link, but it will be available and open to all the people that you want to involve.
So this is important for all your team in your hospital.
For your privacy, because you will be.
Okay, the second point is that I asked the chairman to be very severe on the length of the presentation. No more than 10 minutes in order to have a discussion. So work tonight in order to shorten your presentation. You know, at the American Surgical Association, they have 10 minutes. And I ask to them, how you succeed to have that? And they look at me with surprise. Nobody will give a lecture longer than 10 minutes. It is like this. That means it is cultural. So please, that. And the third point is tomorrow we do a picture of all the Compagnons at 11 o'clock. So please, for those who want to do shopping in Milan, of course, be here at 11 o'clock to have the picture. All the Compagnons, we are 50. And Guido, you are sure you have a good angle for the photo to take the 50 in a line? In a line, in a line.
Yeah, but in this room we had the last meeting before the pandemic, the day before the pandemic. It was in Codogno, so nearby, and we were all happy. The Italian HPB, we founded the new association, and we were more than, and we took a nice picture all together before all of us migrate within the COVID.
Okay, thank you.
I hope there will be not the same situation.
I know the reception now.
Yes. Now there is sorry.
Okay.
There is a the reception is where you had the coffee break, and it's enlarged. The problem is that outside, to my knowledge, there are some mosquitoes. Some, you know already. So.
Some days ago, I proposed René Adam an idea that I think we all together have to think in that, because the Compagnon has transformed in maybe the most important society of HPV surgeons. And I think in each meeting, we can nominate maybe 1 or 2 editors, and we can concentrate our case discussion, our conference, our symposium, just in 1 or 2 issues. And we can elaborate, we can write papers regarding the different issues that we approach, and I'm sure many editors of the best journal will be happy to publish the Compagnon ideas. So I think we have to elaborate this idea. We have to increase it, and from the next, maybe for the next meeting, we have to publish just maybe in 1 issue what the Compagnon, because this is very rich, not to live just in talks. We have to write it.
This is excellent idea. So I propose to applaud the nomination.